move on to the cardiac exam. And the cardiac exam actually includes the vascular exam as well as the heart exam. So the first thing that I'm going to do is check for jugular venous distension. It's also called jugular venous pressure, or JVD or JVP. This is not an exam I'm going to do on every patient. I only test for JVP if I'm worried about increased fluid in the vascular system, such as when a patient has congestive heart failure, okay? So JVP is basically a test that looks at the presence of increased fluid in the internal jugular. The way to do this, it does take some practice. The best way to do this is, first of all, have the patient lying at about a 30-degree angle. So I've lifted this up a little bit. The next step is I have my patient turn his head slightly away from me. Perfect. And what you'll note is that I see right here his IJ, internal jugular vein, okay? And so what I'm looking for is the top of the pulsation of that jugular vein. Now normally it's usually about a few centimeters from the supraclavicular area, so it's about right there. And that is perfectly fine. What I'm checking for is to see if it's elevated. So how do you do that? Well, you need a ruler. So the tricky part here is you've got to first note where the top of the jugular venous pressure is. And if you can notice on this video, on the camera, I'm seeing an increase, the jugular pulse about right there, okay? So the next thing I do, so I note the location of the jugular venous pulse. Now that I've got a visual on where the jugular venous pulse is located, I'm going to place my ruler right at the top of that pulse. I then place the ruler, as you note, parallel to his body. And I'm trying to measure the distance between the bottom of this ruler and the top of his chest, or his sternal notch, technically. And what you'll notice is there really is no difference. He has 0 centimeters of jugular venous distension above the sternal notch. That's how we write it. Now, if he were to have congestive heart failure, and if the jugular venous pulse were higher, I might see the jugular venous pulse here, place my stethoscope, place my ruler higher here, and then I would note that my ruler stands a lot higher above his chest or the sternal notch. And the distance between the bottom of this ruler here, where my thumb is, and his chest wall would be the centimeters of jugular venous pulsation above the sternal notch. So in this case, he would be 2 to 3 centimeters above the sternal notch. So I would say the patient has JVP of 3 centimeters above the sternal notch, or the sternal angle. The next part of the cardiac exam is palpating for the point of maximal impulse, or the PMI. And the PMI is basically the part of the heart that is beating most closely to the chest wall. And I'll tell you why that's important. But first, let me tell you how to do it. The best way to do this is take your hand, palm flat, across the patient's chest here. And what I'm doing is I'm using my entire hand, basically, as a sensory organ, trying to palpate where that point of maximal impulse is. And his PMI, or point of maximal impulse, is right here, exactly where it's supposed to be. So what does here mean? It means mid-clavicular line, 5th intercostal space, exactly where it's supposed to be. Now, if a patient has congestive heart failure or an enlarged heart, that point of maximal impulse is often laterally displaced, and so I would feel the PMI here, which would indicate to me that the heart is slightly enlarged or moved and deviated towards the left. The next part of the cardiac exam, and I think this is the funnest part, is to actually listen to the heart. And you're going to auscultate in 4 areas. This is actually a really powerful tool, because if someone has a valvular abnormality like aortic stenosis or mitral valve prolapse, I can pretty much make the diagnosis with the stethoscope and my ears. So the first thing I'm going to do is use the diaphragm. And with my diaphragm, I'm going to auscultate in the 4 major areas of the heart where we know that the valves and the sounds of valves are transmitted best. So I'm going to auscultate here first in the aortic area, going on to the pulmonic, moving down to the tricuspid, and then laterally to the mitral valve. So these areas are, again, aortic, second intercostal space on the right, pulmonic, second intercostal space on the left, tricuspid, about third or fourth intercostal space here towards the midline next to the sternum, manubrium, and then out laterally for the mitral area. I'm going to do the same by using my bell. And the purpose of listening with the bell is that it allows you to hear lower pitched sounds better than the diaphragm will. So same locations, aortic, pulmonic, tricuspid, mitral. It's important to note that if I hear something abnormal in the aortic section, the sound will transmit up to the clavicle. And so if I hear something abnormal here, like a murmur, I'm going to inch up towards the clavicle to see if the sound radiates up to the neck or to the clavicle. Same goes with the mitral. If I'm listening here and I hear a murmur or an abnormal sound, I'm going to inch outwards to the axilla, because that is where sound from a mitral valve gets transmitted or radiates. I'm going to do the same thing with the patient lying back, right? Listening in those same 4 areas, aortic, pulmonic, tricuspid, mitral. Use my bell, doing the same thing. Aortic, pulmonic, tricuspid, and mitral. The next thing that I do is the vascular exam. And the vascular exam sort of takes place in different areas, right? If you noted, on the neck exam, I went ahead and listened for carotid bruits since I was already at the neck. Again, I want you guys to figure out what system works best for you. The most important thing is to not forget any of the pieces. The first thing that I do is look at the extremities. So I'm going to look at his hands and his nails. One thing that you're going to test for is something called capillary refill. And I don't test for capillary refill on every healthy patient who walks into my clinic. However, if someone's in the emergency room, they're not feeling well, their blood pressure may be low, it's important to check for capillary refill. What does that look like? What you do is I'm going to push down on his nail for a couple of seconds until it turns white. I'm going to quickly then let go and note the time in seconds of how long it takes for his nail to return back to pink. And within 2 seconds, it's back to pink. That's normal. Less than 3 seconds is actually normal. If it took longer, then that would be a sign that his vasculature is depleted of blood, or he's intravascularly depleted, such as in hypotension or any kind of bleed or trauma. The next thing I also look at, since I'm looking at the fingers, is for clubbing and cyanosis, right? Now, if you remember, clubbing and cyanosis tend to be part of the pulmonary exam. But since you're here looking at the hands, it's convenient and time management-wise, it's better to go ahead and examine the hands for both of those. And if you'll notice, there's no bluish discoloration of the nails, so that means there's no cyanosis. And I don't note any clubbing. Now, clubbing is basically, technically, loss of the angle. It's called the unguophalangeal angle, which is loss of the angle between the nail bed and the skin. So there's a normal angle there. When a person has clubbing, they actually lose that angle. Another way to test for clubbing, if you're not cleared just by inspection this way, is have the patient take their fingers and hold their knuckles with each other and connect their fingers. And you will note that you can see that there is an angle there. If he had clubbing, you would not be able to see that area of opening in between his nails. So that covered clubbing and cyanosis. It covered capillary refill. And then lastly, what I look at in the vascular exam before I go to the pulses is I check for edema. Edema is another sign of intravascular volume overload. And so if there's a lot of fluid in his body, I'm going to see swelling in the lower extremity. The best way to check for edema is I place my thumb right along his shin, put a little bit of pressure, and then let go. If he had edema, I would see a doughy indentation here, and that would slowly come back to normal with time. So that's what edema is. Next, I'm going to do a quick examination of the patient's pulses. Whenever you check for pulses, the best way to do it is by checking pulses in both extremities at both times, at the same time. And so first I'm going to check for his radial pulse. I place my finger right above the radial artery here, and I'm checking for timing, so how fast is the pulse. I'm checking for strength of the pulse. Is it very weak? Is it normal? Or is it a bounding pulse? And his pulses are normal here, so that's your radial. The next thing you can check is the brachial pulse, right? So I'll check the brachial pulse on both sides, and that's normal. The other area that I check for the pulses is the carotid. Now, if you've already checked the carotid bruits in the neck exam, you can, that gives you a pretty good idea of what the pulse is, but otherwise, you can always check for the carotid pulses on both sides. Next is the femoral pulse. Now, common sense will tell you if you can feel the pulses well in someone's feet, which we're going to do next, then they probably have a really good femoral pulse. The time clinically when checking the femoral pulse becomes really important is in urgent situations, such as in the emergency room, when a trauma comes in. Oftentimes, or if patients have been bleeding out, they will lose intravascular volume. Your femoral pulse is the best place to check. So how do you do that? I always start laterally. You can check this above. If someone's wearing underwear or thin shorts, you usually can test for the femoral pulse fairly easily. Or if they're unclothed, have the patient modestly covered, and then use your fingers to palpate the femoral pulse. And the best way to do that is I start here at the iliac crest, move a little bit medially, and palpate right here. And I feel a normal femoral pulse here. And you're going to come on the opposite side. Again, start at the iliac crest, move medially, and I'm checking for pulses, and it's normal there. The last two sets of pulses that we check is the posterior tibialis and the dorsalis pedis. Posterior tibialis, you're going to feel here out behind the ankle. And I feel a great pulse here medially. So behind both ankles, that's the posterior tibialis. The dorsalis pedis is noted, the best place to notice is right at the top of the foot. And the easiest way to do this is very lightly place your finger on both sides, noting for the pulse, and his pulses are normal.